So good morning, everyone, and welcome to this consensus update session. I'm here with my moderator colleagues, Dr. Baco and Dr. Rodríguez Sánchez. And our first speaker is Dr. Courtney Phillips, and she will talk to us about prostate cancer consensus on active surveillance.
Morning. Thank you, moderators. Thank you, Dr. Pulaski and Rastenhad, for this opportunity to speak to you on the active surveillance prostate cancer consensus update. I clocked this in under 7 minutes. So I have no financial conflicts of interest. So many of you are probably familiar with the Delphi consensus method, in which several rounds of surveys are handed out, the surveys are tailored down, and eventually, hopefully, we come to a consensus. We opted to use the UCLA RAND methodology with Carolyn Moore's counsel. And the reason why we did this is because it's a little bit more quantitative. There's actually a definition for consensus. So basically what you do is you rate every question on an appropriateness scale, with 1 to 3 being inappropriate, 4 to 6 being uncertain, and 7 to 9 being appropriate. And then a disagreement index is calculated. And if it's greater than or equal to 1, there's no consensus, and less than 1 means consensus. And as many of you have noted, that there's no true way to test a friendship than to send them a UCLA RAND survey. So we had 254 participants, 94 accepted the invitation, and 70 participated in round 1. To date, 46 have participated in round 2, and the data I'm about to present you is updated up and through yesterday's in-person consensus meeting. So age and eligibility, we agree that active surveillance is a good option for many men, and that it can be offered to men from ages 40 to 79, those who are appropriate for it. Parameters that should be included in eligibility include Gleason grade group, PSA density, multiparametric MRI, and cribriform pattern on biopsy. And grade group 2 patients should be considered for active surveillance in selected cases. There are many MRI parameters for eligibility. This isn't surprising, given we are the Focal Therapy Society, and they are listed here. Exclusion criteria for grade group 1 eligibility includes extracapsular extension on MRI. Other eligibility considerations, beyond anticipated life expectancy, we do believe that a comorbidity index should be used to include or exclude patients for active surveillance. And if a 3T MRI is not available on enrollment, a 1.5T MRI with surface detector coil or an endorectal coil is an acceptable substitute. Patients with absolute contraindications to MRIs can also be offered active surveillance when they're eligible. As far as biopsies, if an MRI fusion biopsy is not available at the institution that you are at, then a cognitive fusion biopsy would be the next best option. And confirmatory biopsy should be done with biopsy of any visible lesions, as well as a systematic 12-core biopsy. We agreed that it was inappropriate if somebody was diagnosed with a systematic biopsy that they don't need a confirmatory biopsy, and systematic sampling on confirmatory biopsy is sufficient was also deemed inappropriate. As far as active surveillance, we determined that PSA should be incorporated in active surveillance. I don't think that's a surprise, and we think it should be checked every 6 months. PSA derivatives in MRI should also be incorporated. However, truss without biopsy can be omitted. We agree that MRI changes or new findings on MRI qualify as triggers for immediate or for-cause biopsies. And then for-cause biopsies should again include biopsy of any visible lesions, as well as a systematic 12-core biopsy. It's reasonable to transition to watchful waiting in patients who have not had disease progression and who have a comorbidity or life expectancy less than 10 years. There are certain criteria that would also prompt you to de-escalate the rigor of surveillance, and that includes a health event that would lower your life expectancy to that range. Treatment triggers include progression based on surveillance biopsy to a higher stage, such as T2C or T3, upgrade on biopsy to greater than or equal to grade group 3, or patient noncompliance. If a patient has disease progression and refuses treatment, we think it's reasonable to continue active surveillance as long as the patient understands the risks of this approach. And we also think it's reasonable to recommend that the patient seek out a second opinion. We have a lot of questions remaining, and so I will be battering you guys with another survey. Basically, I think there's a lot of questions about the role of genomic and genetic testing in certain patients, which classifications we should use for standardization, findings on biopsy that make patients active surveillance candidate, findings in grade group 1 patients that would preclude or dissuade you from offering active surveillance, and degree of experience of the radiologist reading these MRIs and the use of the PIRADS nomenclature. The definition, role, timing, and necessity of confirmatory biopsy was very lively yesterday, as was our discussion about DRE, which Dr. Rastenhad can attest to. MRI biopsy and DRE's role in timing and active surveillance, I think, need to be further clarified, and triggers for biopsy other than MRI also need to be clarified. I want to thank our consensus panel. These are the people that read through all of the questions and still talk to me. And thank you.
Thank you, Dr. Phillips. We have no real time to discussing, but I invite Dr. Lorenzo Ramacciotti from USC, Los Angeles, to report on consensus on biopsy.
Hello, everyone. Good morning. Thank you so much for having us here to present our work. I am Lorenzo S. Ramacciotti, a research scholar at USC's Institute of Urology, and today I'll be presenting on behalf of Dr. Andrea Brew and Dr. Nabir Gill, Top Biopsy Steering Committee, USC Urology and Focal Therapy Society. The first round results for an international Delphi consensus for best clinical practices on transperineal prostate biopsy. So there's paucity of transperineal prostate biopsy clinical practices recommendations on guidelines. With that in mind, 2 independent reviewers screened through the most recent and past AUA, EAU, and NCCN guidelines for gaps in recommendations and controversies. Statements were then formulated by steering committee members, and a Delphi survey was then deployed for key stakeholders. These stakeholders are physicians with significant contribution to research on prostate biopsy or that perform a high annual number of prostate biopsies. Initially, authors were identified through a literature search on Scopus on 5-year recent publications on transperineal prostate biopsy, and more participants were recruited through snowball sampling as previously done. Each statement was formulated in a manner that it was a Likert scale from 1 to 5, from strongly agree to strongly disagree. And consensus was defined when participants agreed, at least 75% of participants agreed with the statement. Overall, 108 stakeholders were invited and 77 complete responses were gathered for the first round. Most were urologists, followed by interventional radiology. Of the 66 statements formulated, 30 achieved consensus. Most participants were from North America, followed by Europe, Latin America, and Asia. 48% of participants report performing only transperineal prostate biopsy, 47% report performing both, and about 5% report performing only transrectal prostate biopsy. Approximately 60% of participants perform over 200 annual prostate biopsies, 25% perform between 101 and 200, and 15% less than 100. So regarding patient selection for transperineal prostate biopsy, the panel agreed that patients that had antibiotic resistance on rectal swab, history of recurrent urinary tract infection, history of acute bacterial prostatitis, chronic prostatitis, non-bacterial, patients with diabetes, immunosuppression, healthcare providers, history of rectal bleeding, cardiac valve disease, implanted devices, and indwelling catheters should preferentially undergo transperineal prostate biopsy over transrectal. As for antibiotic prophylaxis in transperineal prostate biopsy, when the panel was asked if antibiotic prophylaxis should never be given or if all patients should receive antibiotic prophylaxis, no consensus was achieved. However, the panel agreed that specific patients should receive antibiotic prophylaxis prior to transperineal prostate biopsy. And what patients are these? The panel agreed that patients with immunosuppression status, history of acute bacterial prostatitis, implanted devices, cardiac valve disease, and indwelling catheter should receive antibiotic prophylaxis prior to transperineal prostate biopsy. And how should antibiotic prophylaxis be administered for these specific patients? The panel agreed that it should be done empirically with oral or injectable antibiotic prophylaxis. As for anesthesia in transperineal prostate biopsy, when the panel was asked which nerve block is adequate and acceptable, no consensus was achieved so far, even though periapical anesthesia was the closest to reaching consensus. As for what is the overall anesthesia preference according to the panel agreed that transperineal prostate biopsy can be routinely done with local anesthesia, with nitrous oxide, sedation/general anesthesia, and it should be ultimately based on surgeon experience, available options, and patient preference. The only statement that reached agreement in patient preparation for transperineal prostate biopsy was that rectal swabbing should not be performed preoperatively for patients undergoing TP biopsy. As for TP biopsy needle guidance, when asked which is acceptable for performing transperineal prostate biopsy under local anesthesia or local anesthesia plus nitrous oxide or sedation, the only one that reached agreement was that probe mount needle guide is acceptable, even though coaxial needle was the closest in both scenarios to reaching consensus. As for terminology, no consensus was achieved whether needle guide assisted should be only used when any type of probe mounted needle guide device is used, and if freehand should be always used when transperineal prostate biopsy is performed without a probe-mounted needle guide or grid template. The only one that achieved consensus was that grid template signifies the use of grid template. As for systematic sampling in transperineal prostate biopsy, the panel agreed that a minimum of 12 cores should be sampled. Still in systematic sampling for transperineal prostate biopsy, when asked which regions should be routinely sampled, the panel agreed that the peripheral zone should be routinely sampled, while the other zones did not reach consensus. As for target sampling in transperineal prostate biopsy, the panel did not agree what is the minimum number of cores that should be sampled per ROI. However, a minimum of 3 cores was close to reaching consensus. However, the panel agreed that the number of targeted cores should be adjusted according to the size of the target lesion. As for ROI location, the panel agreed that when the ROI is located in the apex, transperineal prostate biopsy should be preferred over transrectal prostate biopsy. No consensus was achieved for mid and base. As for the ROI being anterior or posterior, the panel agreed that anterior ROI, when patient has ROI located anteriorly, it should be preferred over transrectal prostate biopsy. However, posterior did not achieve consensus. Lastly, consensus was agreed upon that transperineal prostate biopsy should be preferred over transrectal in all patients undergoing MRI-informed biopsy with target plus systematic biopsy sampling. And when we look at the subset of participants that performed both procedures, consensus was also achieved for this statement. Thank you.
Thank you. Just what's happening in Europe? Based on summary of evidence on rising resistance on ciprofloxacin, the European Medical Agency don't recommend and prohibit, in fact, use the ciprofloxacin in prophylactic setting. And based on that, European Association of Urology guidelines recommend that prostate biopsy should be performed via transperineal approach. That means the faster we phase out transrectal approach in US and Europe, the better it is. Thank you.
If there is not any other question, we are going to move on. I would like to invite the next speaker, Dr. Sriram, who is going to speak about the FDA Panel Report.
Good morning, everyone. So I would like to thank Focal Therapy Society for giving me this opportunity. I'm Sriram. I'm a postdoc research fellow from Duke University. I'm working with Dr. Thomas Pulasic. So I'm here to present the FDA panel report. We had the FDA session on a Thursday morning. So it was a great one, and I would like to thank the FDA panel for giving us a great information on how to conduct a clinical trial. So the first talk was from Dr. Brown, urologist from FDA, on consideration for prostate cancer treatment devices. So his talk was around giving the FDA device regulations and what's the current direction of focal therapy devices, and what are the challenges from the regulatory standpoint in coming with the new techniques and new devices, and what is the future directions for these devices. So, so the pre-market review of devices for prostate cancer management was approved in the year 1976 with the Medical Device Amendment to Food, Drug and Cosmetic Act. Since 1976 to date, there were only two techniques which got approved. One is brachytherapy and cryotherapy, 510K approved. And the table shows the risk-based classification system that's followed by the FDA. Prostate ablation devices comes under the class 2, which requires 510K or de novo method for its approval. Any treatment devices for prostate cancer management will come under class 3 management, where it requires a pre-marketing approval. So there are two pathways for any treatment devices to have a FDA approval. One is tool claim. The second is one is the alternate pathway, which is known as tool claim. Second is the regular pathway, which requires a pre-marketing approval. The alternate pathway is a tool claim, which is most useful for the ablation of any abnormal prostate tissue. This holds true for any devices where we will be using it for ablation of prostate tissues, where focal cryotherapy, focal brachytherapy, focal HIFU will come under. Although focal cryotherapy and brachytherapy got 510K approval, focal HIFU got approval by tool claim method. So what are the recommendations for any technique to get approval by tool claim alternative pathway? So the technique should be for ablation of any prostate tissue. The instrument should be used for the ablation of prostate tissue. The study should have a minimum 100 subjects with a population of mostly grade group 2 disease, and aiming at treating the index lesion, and the follow-up of the study should be minimum for 1 year, with the outcomes based on PSA, prostate cancer specific parameters like PSA and prostate volume, whether if it's going to be a significant decrease or not. The normal pathway is used for any treatment devices in the management of prostate cancer treatment. So the study characteristics which is required for this treatment devices, or the sample size should be minimum 200, and it should be statistically powered. And the objective of the trial should be based on detection of clinically significant prostate cancer to GG1. So, and the study duration should be minimum between 3 to 5 years, where the primary endpoint should be assessed by 3 years, and the follow-up should be there for the 5 years. The endpoints for this clinical trial should be based on the cancer-specific outcomes, biochemical progression-free survival, and overall survival. And the surrogate endpoints will be like failure-free survival, requiring any salvage therapies. So the question based on this trial is, what are the population, the exact age group to be included in this study? Whether it should be men aged less than 45 or between 50 to 80, or can we include any prostate gland size between 20 to 80 gram, or only include those patients with PSA level of less than or equal to 20. So the next consideration that needs to be considered is whether to include those patients with the stage of less than 2 to B, or we can include only those patients with a favorable prognosis. So this is the table showing the endpoints comparison between the two methods for getting FDA approval, prostate cancer treatment and tool claim. So the first one required statistical power of minimum 200 sample size, where the tool claim required 100. And the duration is 3 years for the prostate cancer treatment and 1 year for the tool claim. And the endpoints are mainly cancer-specific in prostate cancer treatment technique methods, and prostate cancer-specific parameters for the tool claim. The questions which have been placed by the FDA during the meeting were, the devices used for focal therapy are categorized by FDA based on the indication as either for management or curative intent. Does Focal Therapy Society have any plans to follow guidelines or definitions related to different types of treatment goals? Whether we should include GG2 or GG3 population in these trials, and if it is there, we should consider whether we are placing these patients in unethically exposing to under-treatment with the aim of giving a good quality of life. And what are the considerations for including patients with a prostate size of less than 20 cc or greater than 80 cc? So do we have an ideal time frame for biopsy in these patients? And are we going to include patients with NCCN guidelines of although the NCCN guidelines state that focal therapy can be done for T2B and T2C tumors, are we going to include more than T2B, T2C tumors? So the next talk was by Dr. Sussman, who is a deputy director of FDA, and his talk was around the regulatory consideration for drug or biological therapy for localized prostate cancer. So there were two pathways for getting approval with regards to any drug or biological samples used in focal ablation. One is traditional approval or accelerated approval, and it mainly depends on the primary endpoint of the study. So if it's going to be a traditional approval, we need to have the endpoint, which is not a surrogate one, which is there to either elongate the prolongation of the life or to have a better life. It includes overall survival, cancer-specific survival, or disease-specific survival. The accelerated approval can be gained for those endpoints which is reasonably likely to predict clinical benefit. But accelerated approval requires post-marketing trials to verify the benefit of these drugs or the biological agents. So the best trial for ablation devices are non-inferiority trials. So we would like to look at whether if it is non-inferior to radical approaches and whether the ablation devices are superior in terms of functional outcomes. Although we have highly effective standard of care for intermediate high-risk localized prostate cancers, so it's better to keep non-inferior than the superiority trials comparing the ablation techniques with the radical approaches. So what are the endpoints which needs to be looked for when doing a study, when doing a trial with focal ablation methods? So the best thing is a local progression where there will not be any risk of bias, and we'll be able to look at the feasibility as compared to overall survival and metastasis-free survival. Since the disease is indolent, it will take longer time for us to come up with the outcome. So what are the ideal endpoints? It should have a direct benefit, and it should be accurate in measurement, and it should have less susceptibility to bias, and it should be feasible for us to study the outcomes. So the FDA authorities are given as a example for conducting a trial. This is based on including focal ablation with surveillance or with surveillance alone. So where the primary endpoint was local progression and secondary endpoint was initiation of any local therapies like radiation or radical prostatectomy. And since it is an alternative pathway, it requires a post-marketing requirement. So the third talk was given by Dr. Parnes from National Cancer Institute on clinical trial endpoints in prostate cancer, where he advised the endpoint should be revolving around the functional outcomes and oncological outcomes. And the functional outcomes include genitourinary, gastrointestinal, and sexual outcomes, and oncological outcomes like grade group progression or time to radical therapy. So the next talk was given by Dr. Plasik from Duke Urology. He was talking about, he given a talk on FTC registry update. Since it is not feasible to conduct RCT in all circumstances, it will be better to have a registry to come up with a real-world data outcomes to substantiate our non-inferiority to the radical approaches. So we have a registry in Duke. So it's an open registry with the aim is to capture the high-quality data, which will help us to give a real-world data outcomes and aids in clinical decision-making. So we have two requirements to have any collaborators. One is getting local IRB approval and data user agreement, and we will be able to support any individual practitioners to universities. So Dr. Plasik gave an update on the current numbers in the registry. So the last talk was given by Dr. Astinat from Northwell Health on how recent advances in imaging and ablation technologies could influence future focal therapy clinical trial design. His talk was mostly on new ablation technologies with its outcome, as well as how imaging modality advancement has an impact on the clinical trial design. So the new ablation technologies, he discussed about the results of new ablation technologies, which was published in the major published trials, and he talked about the imaging advancements in clinical design and how come, what is the role of multiparametric MRI and fusion biopsy in the clinical trial designs. Is it a perfect tool in assessing tumor dimension? Although there were so many studies mentioning about saying that multiparametric magnetic resonance imaging is showing underestimation of prostate cancer geometry. So this was a result showing that MRI underestimated by 7 to 80% of tumor size, which was published, and whether the quality of MRI, does it matters in including in clinical trial design. It was published by Pickford's score, and it has shown that in a large multicenter study that Pickford less than 3 is non-diagnostic. So it's better to have a MRI with high quality to include in a clinical trial design. Whether is there any role of combining imaging modalities and whether it could affect our trial design. So we need to assess whether it's better to include PSA PET-CT with MP-MRI in clinical trial design and how it's going to impact our outcomes. So the recent study has shown that the combination of MRI with PET-CT has shown improves index lesion detection and gross tumor volume and detection of adverse pathology. So the question was whether we are going to include metastasis-free survival. If we are going to include, what is a reasonable time point? And are we going to have any imaging which could replace the biopsy, which needs to be addressed in our future trials? So this is the image shown by Dr. Rastinad, and it shows that right now the focal therapy is supporting the active surveillance, and in the future we are expecting it to replace the red line in the last future paradigm. Thank you.
Thank you very much. So I think this concludes our session, and we can agree that there was strong consensus. And we will now move on to the session on patient selection, and I leave the floor to Dr. Olivares and Dr. Weisach.